Good evening to all my dear students. So, how was your exams? Hope you did well. Ophthalmology seemed to be very simple. Enjoyed giving the exam or not? Okay, so let's start with this session. So, as you see, you can read this disclaimer. So, what we are trying to tell you here is these are all recall based questions, and I even found some question in ophthalmology which seemed to be have to be modified. It was not making sense. I will discuss one by one. So let's start discussing ophthalmology. You all know me, na? I am Dr. Ruchi Rai. Okay, so we start with our first question here. Just 1 minute, let me see. Yeah, I can see you all talking. Now I'm comfortable. Let me start. Okay, so if you look at this first question, what does it say? On your recall basis, it is saying diabetic male developed cataract. Which substance is deposited in the cornea? So this is one question which I really feel has to be modified. As you all know, when you talk about cataract in a diabetic patient, we will talk about snowflake cataract or snowstorm cataract, right? Due to sorbitol accumulation. But what do you see in this image? Do you all recognize what is this? This is, yes, this is copper, right? So copper, is it really related to diabetes? Not. So there is some problem in the recall. We will come to the correct question in the due time. So anyway, we can discuss this, that what you are looking out here is this deposition, which is nothing but copper deposition. So you are looking at the Wilson's ring. And what is this? This is your sunflower cataract. Right. So this is your actually sunflower cataract that you are looking at, and this is your Descemet's membrane deposition of copper, that is Kayser-Fleischer ring, isn't it? So was I saying Wilson's ring? I'm so sorry, that was Wilson's disease. So Kayser-Fleischer ring, as you all remember, is a copper deposition in the Descemet's membrane of the cornea. So this is what I see from the slide here. This is a KF ring, Kayser-Fleischer ring, which is copper deposition, and this is the sunflower cataract. So what should you write here is copper, but again the problem in this question is why has this been mentioned. So we'll look into it in the future what it is, right? Okay. This was the first question we got from you all. We come to the next question here. Right? Yeah. Yes, we will. Okay. So we next talk about is your second question S in, I think this is a very simple question, S in safe strategy of the trachoma. Everybody remembers what was safe strategy? It is a WHO program to control trachoma in a community. What S stands for is surgery, A is antibiotics, right? This is surgery, this is antibiotics, right? Then facial hygiene, environmental cleanliness, isn't it? Cleanliness. So you should know the full form of SAFE. With surgery, they have asked you this also. So here it is very simple. The answer should be surgery. S for surgery. So with surgery, all of you? Yes, it is with surgery. It is trichiasis surgery. Note down one additional, we are going to discuss in detail, but here can you also tell me which antibiotics? I am waiting for the answer. Okay, we will use a thicker pen. So, which antibiotics? Now is it fine? Now is it okay, Pickle? Nice name. So, tell me which antibiotics, now answer me this, Pickle. So, which antibiotics? We will say either oral azithromycin, isn't not looking little more, not defined, but anyway if you are happy with this, or topical tetracycline. Both can be given, but which one is generally preferred is oral azithromycin. Why oral azithro? Because as you know, topical tetracycline is generally given in ointment form. That is why if the compliance is poor, we will prefer oral azithromycin here. Anyway, this is some important point here, but you should know what SAFE stands for. So, we have other questions also on SAFE, like they have also asked you this, that what is the indication of giving a SAFE strategy or applying this program. So, there we are looking at the prevalence of trachoma in any area, and any prevalence of, let us note down, any prevalence of more than 10%. If you want to write this, I think this should be better, more than 10% of prevalence, then this is the indication that we should start SAFE strategy in the trachoma program. Okay. Yes. Yeah, it is 1 gram in adults, correctly answered. Right. Okay, so this question was very comfortable. Can we move to the next question? Let's see. Now look at this question reads that 34-year-old male working as a welder came to with the complaint of pain, redness and watery eyes. What is the management? Now we all know, first of all, very important question, the most common mode of any intraocular foreign body is chisel hammer, or you can say during welding. What you see here, or during welding, but what you are actually seeing here, it says a welder. So what you see here though is an iron particle on the cornea. So if you ask me how to manage this iron particle, we generally scrape the iron and we pad and bandage. Now let's see the alternatives and the options that we have got here. What does it say? Syringe washing, okay, anything, any foreign body inside the eye, of course there has to be copious irrigation has to be done, right? And we have to, syringe washing is one thing. Then antibiotics, yes, in this case we have to give that. Keratoplasty, there is not much role here, it is a superficial thing. So now we are stuck. What should we choose as the answer? So I would say let us work up on these alternatives further and see that what we would like to answer here. Right? Yeah, it's an iron foreign body. It's an iron foreign body, and generally the treatment is scraping with antibiotics. So I think we should, if the best possible in this patient with this clinical picture would be antibiotics. Right? So if this is the clinical picture that has been shown to you, so we will scrape and give antibiotic ointment and pad and bandage. That should be the best option to answer. Right? Okay. So that was about this question. We generally use a 26 gauge needle. It is done under slit lamp. So you should know this as well. We come to what was the next question asked you is position of the lacrimal sac in the orbit. A simple question. It's already given here. Where is the sac? You can see it is on the medial wall. Right? Is there any confusion here? The medial wall, what is the medial wall made up of? Your maxillary bone, then the lacrimal, right? Then the cribriform plate of ethmoid sinus, and then body of sphenoid. These are the 4 bones making the medial wall of your orbit. So the lacrimal sac between the anterior and posterior lacrimal crest is positioned on the lacrimal, right? So we can answer medial wall here. Okay? I hope this is comfortable. It's already, if this was the clinical slide also with you, this was the slide, animated slide. So you can see that it's already showing where it is, isn't it? Yeah. So all of you, this is about the position of lacrimal sac in the orbit. Okay, let me just discuss this with you. If they suppose ask you about the orbit, they must be also asking some few questions around it, like what is the, you should also know what is the weakest wall of the orbit. Again, what is the weakest wall of the orbit? Please don't answer floor. It is again medial wall due to the cribriform plate of ethmoid sinus. ठीक है. So one of few additional points here, that the weakest wall of the orbit, if they ask you, so weakest wall is again the medial wall. Yeah, of the questions were really very comfortable to solve, isn't it? So that's why you should learn ophthalmology very seriously, so that you can master all the questions of your exams. Yeah. And can you tell me which is the wall which is broken in the blowout fractures? What would you answer there? So wall broken, now it is the floor, right? So the floor is actually broken in blowout fractures. We can talk endless around it actually. So this is just to solve your questions here. So we'll take it little in a crisp way. So blowout fracture, it is the floor of the wall, floor of the orbit hona chahiye tha. This should be floor of the orbit, not wall here. So we are talking about floor of the orbit and roof of the orbit, right? So that is the blowout fracture. Okay. So this was one question. Then we come to the next one. Yes, very good. You all are answering nicely. Yes, it is the floor. If you are answering so nicely, can I ask one small question more on this, please? Can you tell me which is the weakest wall of the weakest part of the floor, where it is broken very easily? Can we talk about that? Weakest part. My question is, which is the weakest part of the floor of the orbit? I am waiting for the answer before I go to the next question, just to make it a little more interesting and we should know more. Medial was good. Yes, medial is the answer. Yeah, so that is not a problem. Medial wall, it is not inferior. I asked about blowout fracture, that is why people are answering me inferior. Answer of this question, which is what is the position of the lacrimal sac in the orbit? Of course, it is medial, right? And sac is actually not inside the orbit as such. So again, this question is not a very perfect one here. Okay. That's new. Okay, Pickle. So the most weakest part of the floor is the posteromedial part. Okay, just medial to inferior orbital fissure. We can note down this, right? It is posteromedial part. Okay? All of you comfortable? Chalo, we come to the next then. Next question. Okay, so what was asked? Were they asking you the yoke muscle or the synergist? First, can you let me know this? The question is, which of the following is a synergistic muscle of right lateral rectus? Or were they asking you the contralateral synergist of the right lateral rectus? So I'll wait for your response. Was it synergist or was it contralateral synergist? And is there any difference? Of course there is. Come on, tell me this. Okay, Ms. Viraj, if you are answering C, then we are talking about contralateral synergist. Most probably this must be the question. What is contralateral synergist? Tell me. So, the two muscles of two different eye which are working together, right? So, I'll just solve it in both ways, synergist or contralateral synergist. Let us think together. So, we all are very, very clear about the action of muscles. Are you all clear about the action of muscles? Tell me. So, very quickly, we all know if you talk about the horizontal muscles, right lateral rectus is the abductor. Lateral rectus is an abduction and medial rectus adduction. So, let's quickly just helping you to revise this very quickly first. Wait. Then we will talk about both options, contralateral synergist or synergist. Okay, you want to? Acha, a person was looking on the right side. Okay, if this is the question that the person was looking on the right side, I am talking about the recall, Ramesh. So, if it is looking on the right side, that means we are talking about two muscles of different eyes working together. So, we are talking about yoke muscles, and if we are talking about yoke muscle, we all know right lateral rectus, the yoke muscle has to be left medial rectus, right? So, then this is the answer. Now, if suppose, chalo, I am going to ask you another question on yoke muscle. If they had asked you what is the contralateral synergist or yoke muscle of right superior rectus, So what is a quick tip? Of course, you should be knowing this. The basics should be absolutely very clear that the right superior rectus is what will be the yoke muscle. To understand that, this should be absolutely clear to you that action of elevation and depression is maximum in abducted eye. In an abducted eye, it is the sole action of recti, isn't it? So when your eye is outward deviated, the action of elevation and depression is purely for recti, and an inward deviated eye, it is for obliques, right? So if you have to understand this, of course this will just lengthen the lecture and you all are more in a mood of a quick recall. So I'll just give you the tip and the basics we'll learn the detail little later. So you just have to put every letter opposite. That is a quick tip of taking out what is the yoke muscle of right superior rectus. Just make every letter opposite. It becomes left, inferior, oblique, right? So this first of all you should know. Now let's see the basics also, otherwise it will be bad. So I'll very quickly talk about this. I'll take another 5 minutes only, Ramesh. Action of muscles. You should be very clear that you can easily learn if you divide the muscles like this. Learn in a very simple way, horizontal muscles and vertical muscles, right? So when you say horizontal muscles, we all know lateral rectus abduction and medial rectus adduction. So this is simple and this we know. Talking about vertical muscles, just learn the two mnemonic with me here. One is one is rad. Is says that says that superiors are in tortoise. Superiors are in tortoise. Okay. And what does rad says? Rad says that recti are adductors. Yeah, Shivam. So that's why I have taken this action of muscles. Let's study together. And I would like you all to learn with me here itself, okay. So what I said, when you are learning the action of muscles, you generally divide it into horizontal, vertical. Horizontal, I think everybody has learned with me. Vertical, you have to learn these two mnemonics. You will be very comfortable learning them. Recti are adductors. Now, once you know this, how do we learn the vertical muscles are superior rectus, inferior rectus, superior oblique, inferior oblique. This is it. Okay? Simple. Now we will talk about primary action, secondary action, tertiary action. Okay? Very simple, learn like this. So primary, secondary, tertiary. Tertiary actions, just remember, adduction, abduction are always tertiary action for a vertical muscle. So how would you understand what is primary, what is secondary, what is tertiary? To simplify your life, primary is very important action, less important, or tertiary is least important, but of course it is there. But actually if you see scientifically, primary means in an abducted eye what is the action and secondary means adducted eye what is the action. So abhi us pe mat jao, we just talk like this. So we are now learning together what is the action, what are the actions of vertical muscles. So I said the main action of adduction and abduction, are you listening, is of horizontal muscles. So for vertical muscles, what are these? Tertiary. क्या पढ़ा था अभी हमने? We just read that tertiary में क्या पढ़ा? What did we learn? Recti are what? Adductors. ठीक है? So if recti are adductors, so superior rectus के नीचे I'll write here adduction in below inferior rectus. Oblique पे I'll write here abduction. So my one row is complete in learning the action of muscle. Now we talk about primary action of superior rectus. Everybody remembers is elevation. है ना? Okay. Primary action of inferior rectus again we all know is depression. Secondary action. अब क्या बचा? We have covered elevation. We all know there are 6 movements only: elevation, depression, adduction, abduction. Inward rotation is intorsion. Outward rotation is extorsion. Isn't it? Now we are saying this secondary action of superior rectus. You just learnt with me that superiors are intorters. So I will write here intorsion and I am going to write here extorsion. Done? चलो अब पढ़ते हैं superior oblique. So superior oblique नाम ही बताता है, the name itself is indicating is टेढ़ा काम करेगा. This is my way of explaining it to you. So oblique, so you have to remember if it's superior it will depress, if it is inferior it will elevate. Now, primary action is for obliques is always torsional. Since superiors are in tortus, I will write here intorsion for superior oblique, extorsion for inferior oblique. And as I said, ulta kaam karega, so superior oblique depression and inferior oblique elevation. Easy? So this is how we'll first understand the muscles here and the action of muscles, right? Now we were talking about yoke muscles. So to understand yoke muscles, it's very important to understand this basic principle that when our eye is abducted, the action of elevation and depression is of recti. It's a very important concept. I would like you all to put a box here and note it down. If you can understand this, you will understand everything. So you can write down that in an abducted position, that means outward deviated position, action of elevation and depression is of recti, and vice versa. For adducted position, it will be obliques. Okay, if we can understand this, can you tell me what are the muscles working here? Is very simple to answer. This is what they have asked you, right lateral, left medial. But what are the muscles working when I am looking here? What is this? Right is dextro, left is levo. So when I am looking in the dextro elevation, do you realize my right eye is outward but my left eye is inward? So right ka recti kaam karega, left ka oblique. So if I am looking like this, it is elevation. What are the elevators of your eye? You have just noted down. The elevators are superior rectus, inferior oblique. Okay? When I say dextro elevation, or if you ever get a question like this, divide it into two, elevation and dextro. So elevation, these are the two elevators. Dextro means right eye is outward. Outward eye, which muscle will act? Of course, recti will act. So for outward deviated eye, it will be superior rectus. So I will write here right superior rectus and I will write here left eye ka inferior oblique. If you have understood this, now look at the two things. Is it not what I just taught you, that every letter turn opposite? Right ka left, superior ka inferior, recti ka oblique. So anytime any muscle, yoke muscle or contralateral synergist is asked, you have to answer like this. Correct? Suppose this was a more tricky question and a synergist was asked, though I don't expect so, then can you tell me what would have been the answer? If it was synergist, synergist means same eye, the muscle is assisting the action of the other muscle, right? So what is the action of lateral rectus? Abduction. What did you learn? Obliques are abductors and recti are adductors. So if that case, right lateral rectus means right inferior oblique could have been the answer if it was only synergistic. So now you all have to decide. But if you are, I think Ramesh was telling us that it is, they asked that if you are looking towards your right. So when you say looking towards your right, that means both eye muscles working together. That means we are talking about yoke muscles. In that case, our answer has to be left medial rectus. Okay? So I think now it's very, very clear to you, and it will become more interesting. We'll study together. Yeah. No, nothing is confusing. We'll study together and we'll simplify it as much as possible. Nothing is confusing. Ophthalmology is one of the most interesting subjects. Okay, so once this is clear to you, we will talk, and one more thing which I just missed to make you all familiar with this. This is why you get this diagram. You make this diagram for yourself. Don't you realize this? This is what you make for yoke muscles. It is not complicated. If this is your, suppose, right side of the patient and this is the left side of the patient. So we are just talking about this only, which we just discussed, that this is levo elevation. We are talking about this is dextro elevation. So what are the muscles? Now you are so pro, isn't it? So this becomes levo depression and this becomes your dextro depression. Okay, if you have understood this, so many of you are very happy about this. So can I ask you a simple question before I move to the next? Just one quick one. So if you have understood, we will think again and answer this question, and I want a correct answer. So take few seconds to think and answer. What are the yoke muscles working for levo depression? Chalo, I give you 10 seconds. Levo depression. Okay, a hint is divide the question into depression and levo. Now tell me. Yeah, Pickle, I just told you about synergist. First you answer this, I'll again repeat the synergist part. It is so funny to call you Pickle, but ठीक है, this is what you want us to call you. हाँ? चलो चलो सोचो, बताओ फटाफट. I need some answers. We are in the recall session. We can't give so much time. I have already taken time for this question. Come on, tell me. Okay, let's think. Achha, there is an answer here. Okay, let's see what levodepression. What are the muscles which depress? Inferior rectus, okay, and superior oblique. Very good. Levo means which is an outward eye. It is left eye. So rightly answered by you all. Awesome. So it becomes left inferior rectus, right superior oblique. Wonderful. Sujata, Pickle, very good. So now you all are very clear how to answer the questions on yoke muscle, right? And do you realize again it is every letter opposite. यहाँ पे भी वही है ना? Every letter opposite. Right का left, left का right, inferior, superior, recti, oblique. Okay, you wanted me to explain you the synergist part. So if it is a synergist, it means, say, I don't think this was the question actually. They don't ask even for the other exams. So anyway, if you still want to understand, you have understood the action of muscles, you have learnt with me now. If you have learnt with me now, just imagine, just think yourself, same eye, two muscles of same action. So how can you correlate with that? That recti is lateral rectus has single action abduction. So now what I have to think in the vertical muscles, which are the muscles which are also causing abduction. So I would say right side ka hai na, so right superior oblique, right inferior oblique, you can say can be a part of synergist. But here right, there is only one right inferior oblique, superior oblique is left is given, so we will answer this. But I don't think this is the question, so please don't worry. We will solve it as contralateral synergist or as told when you are looking to the right. We are talking about yoke muscles. ठीक है? चलो. Come to the next question now, all of you. Okay, so very interesting this one. Very simple question. They are asking you the bitemporal hemianopia indicates that the lesion is at. Okay, so whenever we are talking about, now this needs a quick mention of the visual pathway and the lesions. A little bit quick, not too much in detail, but yes, basic. See, basic where we make a mistake and we are not able to understand when we don't understand this concept that the projection of the retina is opposite, the coordinates are opposite. What do I mean to say? If it is superior fibers are damaged, you get inferior field effect. Inferior fibers are damaged, superior field effect. Then I say if it is the temporal fibers damaged, medial. So this is what you have to understand, that the field is always opposite to anatomy. Correct? If you can understand, you can solve all the questions on your lesions of visual path. Field will be opposite of it. So everybody remembers that. So if I very quickly draw this for you, a very simplified one I am drawing for you. Okay, see, I am saying this is your left retina, this is your right retina. I equally divide it into two parts. This is nasal, this is temporal, this is nasal, this is temporal. I am using a little thinner pen. I hope you will understand why it is causing problem in drawing. Okay, Pickle. So ab isko dekho, temporal, nasal, temporal. Now what we have learned, the nasal fibers they decussate, temporal will not decussate. Ye to sabko yaad hai. And then what? This is your optic nerve, this is optic chiasma, optic tract. After that kya aata hai? Lateral geniculate body. ठीक है? Then optic radiations which some pass through temporal and some through parietal. So I'll draw like this very simplified diagram and then comes your visual cortex. ठीक है? So now once you have understood this, we all know that any lesion, okay, of one very quick, I cannot take everything in detail, but still I would like to give a quick idea here. So optic nerve lesion on one side if whole nerve is gone. Can you tell me what? Suppose I take the left sided as an example. If I am taking the left sided lesions, No, it is not about that crossing I am talking about, Sujata. You have misunderstood. What we are trying to tell you here is that the projection of retina is opposite, means suppose there is a retinal detachment on your superior retina, the field effect, if you will chart, will come inferior. Of course, the fibers that decussate in a visual pathway, this is now an absolutely different part I am talking about, is nasal fibers only. So just hold, once you will listen, you will understand what I am saying. We are saying that suppose the left side whole nerve is gone, life is simple, we will say okay, left side number 1 lesion hai, this number 1 lesion is causing ipsilateral blindness because the whole nerve, optic nerve is gone, so it has to be ipsilateral blindness, right. Now, if it is now coming to chiasma, everybody understands if 2 nasal fibers are gone, it has to be temporal field. This is what, Sujata, I am trying to make you understand that it is always opposite. Nasal fiber defect will not lead to nasal field defect. This was my message. So, it is a nasal fibers, so field effect has to be temporal, and this was your question of number 2 lesion. So, agar nasal fibers gaye and if these are the 2 fields of the left and right eye, what do I say? We will say temporal of either are gone, and this is what is bitemporal hemianopia. Is it okay? This is what you are seeing in the in your slide that is shown there, right? So, the answer there will be, your answer is chiasma, isn't it? Now, think yourself, this was a temporal of left and the nasal of right, and any lesion at the tract. Can we think together? Any lesion of the tract. So, left temporal is gone. So, left temporal is gone means nasal field defect. Please remember the shaded part is the one which is defect. So, left sided nasal field defect and right sided temporal field defect. Do you agree with me? This is what I have been indicating. Sujata, where are you? Are you clear now? Yeah. Why, what are you referring here for meningiomas and multiple sclerosis? You can explain me again, please. You are asking something? No, Mayer's loop and Baum's loop will unnecessary. I will go into that in later part, not in the recall session. So, that we will be talking about in the optic radiations. I am not giving a total detail, I am just giving you a first step here to make you understand that the answer was chiasma, right. So, and what is very important, many students come to me and tell me, okay, this was something I could not understand and that is the reason. So, that is why I started with this, ki first understand this, that the projection of retina is opposite. So, if nasal fibers are going, there is a lesion there, you always get a temporal field effect, right. This is what I wanted to say. So, here we are talking about tract lesion and of course, radiation lesion, again it is almost the same thing. Of course, we will talk in detail about Mayer's loop and Baum's loop later, okay? And of course, the cord. So, if you understand, just listen this one, very simple, there is no further decussation, it is left sided temporal, right sided nasal in the tract, in the optic tract, in the optic tract, in the optic radiation, in the visual cortex. So, very interesting, in whether it is number 3 tract lesion or radiation lesion or cortex lesion, it is always it is always homonymous hemianopia, sorry, right. So, it is always this one. Now, of course, there are many other details around it, but first understand the basics, that how that it is opposite, right. So, this is a very big topic and it is a lot to discuss in a visual pathway lesion. So, we can do that later. So, here what is the answer? It is chiasma. You can see here that this is your 2 temporal gone. So, our answer will be optic chiasma. It is a very simple question, right. Okay, we come to the next one. What is the next question? Yeah, Varun. Yeah, so it is very simple. Yes, I understand, but I was just trying to give you the concept. Okay. Okay, so xerophthalmia, we all know xerophthalmia. What is xerophthalmia? Is vitamin A deficiency. Again, I could just say, okay, it's a quick question, vitamin A deficiency, this is xerophthalmia, right? But can we quickly revise xerophthalmia then here? Good opportunity to. So, when you say xerophthalmia causes dry eyes due to deficiency of, we know we are talking about, and what is xerosis? It is drying, right? And this is epithelial xerosis. Xerophthalmia actually is epithelial drying or epithelial xerosis. Now, How will you learn the features? By grading. What is the WHO grading here? It's a factual question, but I'll just give you some more idea about what are the questions asked. So if you talk about x1 is divided into A and B, right? So x1 A, what is the, sorry, it will start with xn and then x1a. So first we will write xn, then x1 AB, then x2, let me put it like this first, then 3AB, and then xs and xf. This is what it is. Okay, one by one, everybody remembers this. Xn is night blindness, this is nyctalopia. So we all should know this very clearly, that vitamin is a very important component of your rods, which is responsible for night vision, so night blindness. Then starts the drying process and xerosis. First it will involve the conjunctiva, so there is a conjunctival xerosis. And after conjunctival xerosis, when it is too much drying, right, what is the next thing that is happening here is Bitot spot, right. We all know this. 2 is your corneal xerosis, which is then leading to melting of the cornea, and if it is less than 1/3 of the melting of the cornea, this is keratomalacia, we call it 3A, and if it is more, this is 3, more than 1/3 is 3B. What is excess? I am writing here, it is the scarring, corneal scarring due to xerophthalmia, this is excess, and XF, as you all know, is xerophthalmic fundus. What is a xerophthalmic fundus? It is a white spotted fundus, right. So vitamin A dose, if they have asked you, then you will write here, what will you write? If your patient is more than 1 year, they must have mentioned the age of the patient. Anything more than 1 year of age, you will give 1 lakh international unit on 0, 1 and 14th day. This is very important. Injectable vitamin A, if they have asked this, 1 lakh international unit, and what is very important they want to know from you is 1 injection you give today, 1 tomorrow, and 1 after 2 weeks, 14th, 1, 0, 1 and 14th day. Okay? So if this was asked, this is it. Can I also tell you a few points here, 1 or 2? Okay, if less than 8 months, then you have to halve the dose, and less than 1 year you halve the dose. And if you are giving oral, in each case you double the dose. Okay? Okay, Nani? Should I call you NI? What should I pronounce this? Huh? So anyway, so injectable less than 1 year, you should say 50,000 instead of 1 lakh. 50,000 international unit at 0, 1 and 14th day. Okay? And if I am giving oral, then this one will become 2 lakh, that one will become 1 lakh. So this way. Right? Okay. So, I was trying to give you a few more points on this WHO grading. So, one question they have asked you, which is the earliest feature. Of course, we all know we should answer earliest feature of vitamin A deficiency is nyctalopia, right? And second thing, very interesting question for you all, which is the most common site where you get a Bitot spot. So, where do you get a Bitot spot? What is the most common site? What will you answer here? Of course, drying will be more. See, the tear, think with me. Tear is draining medially. You just learned that the lacrimal sac is medially, right? So when the tear is collecting at the nasal part and it is flowing medially, dryness is more on the temporal side. That is why we will answer that Bitot spot is more common temporally. It is more common temporally. Okay? So a few more points around it for your convenience. Okay. Shall we go to the next question now? Okay, so we are talking about the treatment, Vikal. We will have to see it again. Let's see it again what we have studied. When we talk about the treatment of vitamin A deficiency, this is what you have to learn. Okay, we come to the next question here. A 70-year-old may, okay, now this is one you all have to decide what type of question had come. I really want the real question from you all. It doesn't make sense to me that a 70-year-old male whose cataract surgery is already done a year ago came with fibrosis of nucleus. Are we talking about the past that he came due to nucleus sclerosis, not fibrosis? Then what could have, I really don't understand what was the question. But if you look at the options that you all have given to me, I feel they are trying to ask anything around nucleus sclerosis. So do you all know about nuclear sclerosis and what will it cause? Let me quickly explain this to you, because this is what I find sensible around this question. So can you all? Acha, hardening sclerosis na. So okay, theek hai. So if the question is something like this, let's try to understand this question first. To understand this question, we are actually trying to talk about your second sight of old age. Now what is this? Chalo, pay attention, we'll make it very interesting. Do you all know what is accommodation? We all know this. So when you are looking at the far and then you look at the near, what happens to your eye? There is convergence, there is meiosis, and there is what? Accommodation. Okay, what happens in accommodation? We say there are 3 steps. What are the 3 steps? Keep listening, it's an interesting story. I hope you are noting down and making diagrams with me. That's one thing you should always do. Don't just write the answer. Maybe if you have missed it, you can start now here itself. Please keep drawing, because this is very, very important. Picture memory always plays a lot of role. You should always draw diagrams. Okay, so we talk about here, coming back to I was explaining accommodation. If these are the ciliary muscles, this is the lens, and these are the zonules. Okay? I am only drawing this much at present. See, a very, very simplified diagram of the eye here. So what happens when you are looking from far to near? Number 1, your ciliary muscles, they contract. Now when there is a contraction of ciliary muscles, what happens is zonules relax. Many of you get confused. How will it relax? Try to understand, this is a section. Your eye is like this, the ciliary body, iris is like this, so ciliary body is like this, and the zonules are attached like this. So when the ciliary body muscles will contract, the zonules are going to become loosened. Okay? So the zonules will relax. And when the zonules relax, what is happening? There is a mild increase in curvature of the lens. And what you have to understand, the basic optics, that more the curvature, more is the refractive power. So if I have to look from far to near, do you realize I need more power, and this is being taken care by my eye by the process of accommodation, by slightly increasing the lens curvature, right? Okay. So once we know this, and do you understand that what happens after the age of 40 years and above? Their ciliary muscles, they become very weak, right? Your nucleus is now rigid, the lens is rigid, it cannot change. So the curvature cannot change. So now the accommodation is not proper. So when I am looking at the far, I am better. If I look without glasses, I will see like this. If I have to look near, I cannot focus. I am better like this. So what is this? Why am I not able to see near? Because my refractive power is not increasing. Why it is not increasing? Ciliary muscles are not contracting properly. So is this an error of refraction? No. It is error of accommodation. And this error of accommodation is what is called presbyopia. I am just discussing things around your options so that you are clear with this, right? And what is the treatment after this? Also, just like graying of hairs, the presbyopia is a very physiological thing. It will happen to everyone. So what you have to do here is just increase the refractive power. How to increase? Convex lenses, right? Okay, you increase the refractive power by convex lenses. Do I need it for far? No, it's for only near. So convex lenses only for near, which are called presbyopic glasses or near glasses. Okay? Why did I tell you? You should be very clear about first what is presbyopia. It's an error of accommodation. Okay, coming back to nuclear sclerosis, right? So what happens here? What do you say here? Suppose a patient came to me, right? He is an old patient of around 60-65 years and he comes for a refraction, right? And he says, Dekh lijiye, I am getting old, maybe I am developing some problem in my eye, it's a regular checkup and I am trying to figure it out. So when I am examining this patient, then what happens is that he was using the near glass already of plus 2.5 diopter spherical. When I did my refraction, I gave him little lesser, maybe plus 2.25 or maybe plus 2. He is very happy. Oh my God, what a lucky man I am. In old age, people get diseases. Mera to chashme ka number bhi kam ho raha. I am just the lucky one. Even the specs number is decreasing. But actually what is happening, and this is what is called, this process is what is called second sight of old age. Interesting. So why is the second sight of old age is happening in this patient? Is he really lucky? No, he's not anything special. He's not anyone special here. He is developing nuclear sclerosis, but it's in a very early stage. It is not hampering his vision. But that nuclear sclerosis, which you all just mentioned, is when this nuclear sclerosis, Pickle, I hope you are not, it's not sarcastic. You are able to read, na? Okay, so this nuclear sclerosis, you see, what will happen? Let's concentrate here. Let me finish the story. Is hardening of the nucleus. This will increase the refractive index of the lens. So the refractive power of the lens is more. So do you realize if the refractive power of lens has increased, I will need lesser assistance on my specs. That is why there is improvement in his glasses. So this is what you have to understand. When you say more refractive power, it is myopia. Isn't it? More towards more is myopic shift. More refractive power. If you ever forget, basic refractive error concept should be clear. M for M, myopia is more power in the eye. Whatever I need to focus on the retina, it is more than that. If it is more than that, that is why it will bend very early and therefore the image is in front. This is myopia, isn't it? Now, in this situation, what is happening? Sclerosis of the nucleus has increased the refractive power of the lens. Myopic shift. So it is due to what? Increase the refractive index of the lens. So now do you realize what should be the answer if it was nuclear sclerosis? Index myopia. So if we go back to your question here, it should be index myopia. Now you know what is presbyopia and this. So there is nothing like index hypermetropia, you have to answer index myopia. Okay? Now is it clear? What do you want me to discuss? Curvature myopia. Okay. So Asif, if there was curvature myopia, do you understand it is a simple term which means more curvature, more the refractive power. But here it should be index myopia because it was more refractive index of the lens. Okay? Myopia means more power. Simple. Okay, Nani, your question about macular sparing, big case, something related with the macular sparing in two options. Okay, so for that so macular sparing. Acha, okay, I'll quickly go to visual cortex lesion at the end. Let me first finish with the questions. If I have time, I'll do that. Okay, thank you so much. Yeah, thank you. Okay, so we come to the next one. Let me finish the question. I'll discuss very quickly about, actually we need to have a proper discussion on the visual pathway lesions. That will take time. Maybe when we discuss the questions, we'll again take it, right? Abhi to ye recall hai na, and I'm telling you more than what, but it's good. We should enjoy the discussion also, isn't it? Chalo, is pe batao. See, this was the question given to me. The question says a 10-year-old child is diagnosed with, so you all have said that 10-year-old child is diagnosed with amblyopia in one eye. What will be the best treatment? What have you answered? I would like to know this from you all. What have you answered if this was the question? Chalo batao. Tell me. Acha, so all of you, do you realize that will you be able to treat amblyopia in a 10-year-old child? Amblyopia therapy is effective till ideally maximum 6 years, and maximum you can extend theoretically is 8 years. But I have seen the best results up to 6 years. So here is the catch point. He is saying 10-year-old you all have. So either this recall may it is not 10 year. Do you remember 10 year? And if it is not, it was anisometropic, whatever type of amblyopia. Amblyopia means that when you are trying to correct the refractive error with the specs, if suppose the child has vision of your 6/12, right, and you want the vision to come to, it is vision of 6/12, Now when you are trying to correct it, that is vision improves to 6/6, it is not happening with any type of lenses. That is why we are saying it's a partial loss of vision. Amblyopia is this. That means this is what you have to understand here. Whatever strabismic amblyopia, anisometropic, any form of amblyopia, the therapy is effective only till 6 to 8 years. So are you, Poonam? So, बताओ फिर क्या करना है, कैसे क्या? I don't know about these questions. Were these the options here? What will I observe also? I know that this child will not improve. I can help the child, I can prognosticate the parent, and I can tell the child that okay, this is the best you can have the vision. Forget it, enjoy your life, specs pehno, see that it will not deteriorate also much. Because whatever has been done has been done. You're stamped by 6 to 8 years. So I think there is some change in the question, something more in this question. We will work it out, right? So, but very quickly, yes, if as you all said, occlusion. So just remember this, that when you talk about occlusion, that is the choice of treatment. Can you all tell me which eye will you occlude? If it was 7-year-old child, then life is simple, then our answer is occlusion. If we make it 7-year-old child, then it is absolutely simple, till 8 years then you should answer occlusion. But occlusion of which eye you should, can you all tell me? Yes, Manish, very nice. Please, it should be normal eye. Sabko pata hai na that amblyopia is nothing but lazy eye? Huh? So you want to close the normal eye, suppose this one is the amblyopia, so you want to close to stimulate, to push that lazy person to work. So you close the normal eye so that the amblyopic eye is stimulated. This is what you are doing, na? So please remember that you don't occlude the amblyopic eye, it will become more lazy, good for nothing, it's already. Huh? And if you occlude the normal too much, that can also become lazy. So, how much occlusion for the normal? Just remember, the occlusion pattern should not be more than 4 to 6 hours per day. And okay, I'll tell you one more additional point here, that if it also how much to occlude depends on the age. Suppose the child is 1 year, it is 1:1, means one day you occlude, one day you open. Now, as the age increases, so the challenge increases. Now the time of occlusion is increasing, 2:1, 3 year, 3:1. And so on till it goes to 6 years, right, where we say 6:1. This is the main ratio that you have to understand, right. So, as the age increases, the challenge is more to how to treat this amblyopia. Yes. Okay, so now you will never forget na, that you have to not occlude the lazy eye, you have to occlude the normal eye. But that is also has some schedule of occlusion. Okay, we come to the next question. So, if it was 7-year-old child, we are answering occlusion therapy, done. We come to the next question. Now, look at this image. Guys, tell me, was this the image in the question first of all? I first want some feedback from you all. Exactly, this was it? Because I don't find its macular normal here. So, it seems to have changes. It could be edematous. And if I look at the CD ratio here, so when you look at the CD ratio in this disc and cup, this is the bending it is showing here. So it is not a very big bending or something. So we shouldn't be calling it so quickly that there is any cupping of the disc. So if you would say yes, this was the image. 2 images. CRAO, we have a question, Nani, we will talk about that. Minali, what are you talking about? Which child is on specs? Even if the child is on specs, we occlude. Do you know how we do that? So, we can still use patches, na? And there is also one method of occlusion is penalization, when you have really maintained the vision between 6/6 in both eyes, even then you don't suddenly stop occlusion and you give your this atropine eye drops weekly to maintain that, because as you know, atropine will naturally, what is atropine? It's the strongest cycloplegic, it is paralyzing your ciliary muscles. So क्या होगा, focus कम होता है, so the image is not formed clearly, it is almost equal to occlusion. Okay, so ये even with the specs you have to occlude. Okay, so there is Manish, if it is 10 year, we are not treating amblyopia. Nothing is happening. We are just giving the refractive correction. And the child has to be with this only. Live with this. Okay. Now, there is no disc finding. I don't find anything significant here. Papilledema, no, there should be blurring of disc margin if you all are discussing this image. Okay, so if the question was that the child was wearing specs and that did not improve with the specs, the vision is not improving, then this question is indicating that there has been amblyopia. In that case, our answer becomes occlusion. 99% this must be the question. They must have given you something like this. Okay? Yeah. Even if papillitis is mentioned, Dr. Chaudhary, you have to understand that there is no blurring of disc margin. इसमें हम कहाँ बोलेंगे papillitis? Why we will say so here? Okay, you feel like there is some there has to be some blurring of disc margin, na? So that is another thing that is not here. I don't find blurring of disc margin. Even the CD ratio is significantly not increased or anything. And hypoplasia optic nerve, when optic disc is small, you get a double ring sign here, which is not there. Papilledema is not there, so I am left with this only. If this was the image, I would prefer to answer this. So again, we have to think here, right? Yeah. Right, can we go to the next question here now? Okay, we come to the next question. This was a very obvious or simple question. I think you all have answered correctly. 40-year-old male develops ptosis worsening during the day. Any ptosis worsening during the day. Typical of myasthenia gravis. Improved by neostigmine. Everything is given, all the indications here. Just know what is myasthenia gravis, right? So you all know it is antibody against the acetylcholine postsynaptic receptors, isn't it? So, eye point of view, you should know that the patient is mainly going to present with ptosis and diplopia, right? Yes, so the answer is myasthenia here. We will talk in detail about the myasthenia in further discussions. Just remember this. Okay? Okay. Then we talk about the next question. Okay, so this was the below image diagnostic of cherry red spot. I think this is what you were talking about, Nani? Cherry red spot? Was this the image? It's so difficult to again tell which image and to really recreate the image, isn't it? But typical ones you can. Yeah, very good. So all of you have answered this correctly. So very quickly, do you all know what are the causes of cherry red spot? Do you all know the causes of cherry red spot? Chalo, learn with me all of you. Cherry red spot. I'll tell you some interesting thing. Why we get a cherry red spot? Concept should be clear. So first be alert. We learn the causes like this. If you have learnt your first blunt trauma, so one is your Berlin's edema. Hai na? One causes Berlin's edema. What is the other name of Berlin's edema? We also call it commotio retini. Commotio retini. Okay. Second, as you all said, is CRAO. Central retinal artery occlusion. And third, you can learn like this with me, like depositions. Right, like gangliosidosis and sphingolipidosis, Tay-Sachs disease, Niemann-Pick, Gaucher's, you do get cherry red spot in Gaucher's. This is very debatable, so I am telling you. So all those I will just say simply depositions. So these are the basic causes of cherry red spot. So anyway, why are we getting a cherry red spot? So that is very interesting. You should all know that the very center of the retina does not have all the 10 layers. We have 10 layers in the retina. So the very center does not have all the 10 layers. So in the fovea area and foveola area, so foveola has only 5 layers, fovea has only 6 layers. So what happens? When there is edema, you all know the blood vessels are in the layers that is between outer plexiform, inner nuclear, right? Or the blood vessels are along the nerve fiber layer. So naturally edema will start from there, right? So what happens? When all the layers are not at the center of the fovea, everywhere there is edema. Let's see the picture. Let's see the picture. Everywhere there is edema. So you see the edema around, but the very center is shining red. This is actually the choroid which is shining from behind because there is no edema out there. This is what is cherry red spot. So whether it is edema due to Berlin's edema or we are getting the edema in case of central retinal artery occlusion, this is the reason that you get a cherry red spot. Right? Now you will ask me, ma'am, it's okay, then what about depositions? So in depositions, just remember, sorry. So in depositions, all these are deposited in ganglion cell layer. Again, this layer is absent at the very center of the fovea. And therefore, you get this background choroidal flow, this redness is seen. This is the cause of cherry red spot. Okay? Again, clear your concepts, then it's fun to learn things. Okay. So, that was about the answer. You have all have answered correctly. Very nice. So, this was our recall for ophthalmology. Nice seeing you all and studying with you all, discussing with you all. I am always in reach and you can always discuss your doubts with me, right? Features, now coming to the features of the Elite Pack, I think you all are already here, you should be introduced to this. So, PrepLadder Elite Pack, it has updated new video lectures for all the 19 subjects, both in English and English. Next edition of question bank with 70% clinical questions, notes that are in line with video lectures, right? Treasures for easy and quick revision, rapid revision and snapshot videos, mock tests based on, I think I want to be a student again after listening, reading all this. So life is so easy with all this. Anyway, right? So all the best to all of you. Work hard, stay blessed and keep smiling. Thank you. Anything else? Am I missing any doubt which I have not cleared? Yeah, Pickle, I am going to start all that. We will do this. Give me some time. We will start with all this, right? Thank you. Anything else? Very soon, very soon, very soon. ठीक है? Okay, thank you.